Son, your long hair and crazy hat should tell you exactly what's happening here. Do you know why I pulled you over?
Dude, bro, I'm just like checking out the waves here, man. You know, I'm Aaron Bright, SB in the house, just checking out on the ladies and the waves and gonna catch me some tubes.
Oh, you know what? You remind me of a post-traumatic iritis. Right now things seem okay, like a pleasant young man, but I know deep down, you're just a pain in the behind. You're gonna cause me no degree of difficulty, especially in a couple days.
Man, officer, it's legal in California, man. That's where we're at. Relax.
Dr. Morrison, save us from ourselves.
Oh, Lordy. All right, boys. Well, welcome to non-penetrating eye injuries. That's what we're talking about today, and specifically in kids. So non-penetrating eye injuries in children. Are you ready? Stoner to clerk, are you ready?
I'm not a stoner, man. I'm a surfer.
That's ubiquitous.
Relax,
Officer.
and a CEO of a company.
I would like to speak in that young man's defense. Why does everyone think he's stoned all the time? He's just relaxed.
Seriously, man. Just checking out the waves.
All right, boys, let's get going. So non-penetrating eye injuries in kids. Now, I'm going to start out by saying you should never patch an eye like this, okay? Don't stick a Band-Aid over a kiddo's eyeball. But we are going to talk about protecting the eye with shields in certain scenarios. So let's dive right into this. So in general, there are basic principles of assessing any type of eye trauma. Now, of course, managing other life-threatening injuries in addition to the eyeball is obvious and important. We're going to rule out ruptured globe. We're going to talk about how to do that in a minute. And really, you want to assess vision in both eyes. You want to check for light perception and visual acuity. This can be tricky in little kids, especially when they're nonverbal or they may be very scared or they may be unconscious. So how do you do this? You're going to look for a reflex contraction of the eyelid to confirm light perception in nonverbal kids. And that's how you know they have light perception in both eyes. And honestly, you can have a lower threshold to consult ophthalmology with kids in general because it's just challenging at baseline. So just know that they are available. All right, really important. How do you rule out a ruptured globe? Now, red flags for this start with the history. So if you have a history that's concerning of a high speed, projectile injury or a metal fragment or a baseball hitting their eye, you need to be concerned. Certainly, these patients will have a decreased visual acuity. On exam, you're going to see a Seidel sign. I'm going to show you an example of that in a moment, but where you put fluorescein in the eye and you see that nice waterfall appearance, that is not good. That means that's a vitreous kind of pouring out of the eye there. If you see a teardrop shaped pupil, that's concerning for a ruptured globe. And then certainly these patients will often have a concomitant hyphema. There may be a full thickness lid laceration just based on the impact, and they may have a corneal laceration. So if you think you have a ruptured open globe, then you should actually take like a styrofoam cup or a metal shield, something that's off of the eye itself. It's not going to put pressure on it. It's not going to touch it. You can tape around it, but basically it's just to prevent the eye from getting hit again between the time you're sending the patient or ophthalmology is coming to see that patient in the emergency department. Keeping their head of the bed up beyond 45 degrees is important, and then updating their tetanus as needed. All right, here's an example of that Seidel. You see the fluorescein kind of water falling down there.
Yeah, it's like a wave. That's like totally a wave. You see that wave, man? It's just like beautiful.
Never in my life have I seen such a fine example of Seidel sign. In fact, never in my life have I actually seen it until today.
Yes, exactly. All right. This is far more common. Thankfully, ruptured globes are not. But corneal abrasions, this is bread and butter eye injuries, especially in kids. They're going to have that history, right? If something flew into their eye, you usually don't know what it is. They may have severe, sharp pain. They'll have that foreign body sensation, and it'll be worse when they're blinking, or it'll cause a lot of tearing. You're going to diagnose this again with fluorescein and also using a Woods lamp. And thankfully, most of these heal on their own. The cornea heals very quickly. So within 1 to 2 days, they'll heal up on their own. So what should we do? We should give them some topical pain medication. Sure, it's important, but don't send them home with that topical anesthetic. Don't do that because that can lead to ulcerations, etc. And topical antibiotics are important. And honestly, whether you're using drops or sometimes I like to use the thicker goo, I think the antibiotic ointment is nicer because it actually helps fill in that area that's abrased there on the cornea. And then you can refer these patients to ophtho if they need it, if you think that they're going to develop a traumatic iritis or they have a fixed irregular pupil. Ocular burns is another common thing, and this is typically, right, little Johnny's running around while mom or dad is mopping the floor, and maybe they have some bleach out. This is common. You get it splashed in the eye. What's the first thing you want to do is irrigate, which can be hard with kids. Knowing that alkali solutions are worse than acidic solutions because they actually cause a lot more necrosis and it's faster penetrating, deeper penetrating injuries. So the first thing you want to do is check the pH of the eye. And then you want to just continuously irrigate for the next 30 minutes. And every 15 to 30 minutes, you're going to repeat a pH check. You're going to keep doing that until you can get the pH within like close to 7. So between 6.5 and 7.5, you want to get that pH fixed as quickly as possible. This is going to require some topical pain control. And then afterwards, you're going to want to send them home with topical antibiotics. And ophthalmology may recommend steroids as well. So speak to your ophthalmologist. Certainly, these patients are all going to follow up with them as well. Traumatic hyphema. Now, this can happen usually from direct trauma. And typically, we don't memorize the grades of things, but in this is actually important. So are you boys paying attention? Surfer man and
totally, man. I got a grade of 4 in my
Officer Orman. All right. So
I got a grade of 4.
The way to break this up is grade 1 is less than a third, grade 2 is less than half. Grade 3 is greater than half, and grade 4 is basically when the complete anterior chamber is filled with blood. Now, I can simplify this much easier. Just know that if you have blood in less than 50% of the anterior chamber, that's considered minor. These patients can follow up as an outpatient. Okay. If it's more than 50%, that's 3 and 4, then those patients all need to be admitted. So we're going to get back to that in a minute, but that's the easier way to remember it. Less than 50% and greater than 50%.
Sometimes, kid, I like to have pumpkin pie for dinner. You know what I'm saying? All right, now I like to eat this whole damn pumpkin pie. The whole damn thing. And if I eat the whole damn, it's big. If I eat the whole damn thing, let me tell you what, I'm going to be stuffed. No way I can go home. But what I really like to do for dinner is right there where the whipped cream is. It's a whipped cream. I like to eat the top part of the crust and the whipped cream, just the top half of it. I feel pretty good. I can go home. That's like a hyphema.
All right, there are certain patients you need to worry about, and those are patients with coagulopathies. So sickle cell patients, hemophiliacs, and von Willebrand's disease. Those are patients that if they have those other blood disorders, you're probably going to admit them regardless of the grade of hyphema they have. So how do we treat hyphemas? I've already mentioned you're going to keep that head of the bed elevated. You can use an eye shield, again, that metallic shield, or even a plastic or paper cup. Pain control, certainly. And then you can talk to your ophthalmologist about steroids or antifibrinolytics. Now, disposition, we've already talked about, but this is important. They're going to go home if they don't have a coagulopathy and it's less than 50%. You're going to admit them if they have a coagulopathy, you suspect child abuse, or it's greater than 50%. All right. Orbital fractures. We see this quite a bit. My son plays baseball, so I always worry about this when the baseball comes and hits a kid in the face. So a blowout fracture, these are actually pretty common because those bones are pretty thin up here, right? And really the main concern is not just the fracture alone, but really if their extraocular movements are intact or if they have some entrapment of that eye muscle. So if the inferior rectus muscle gets entrapped in the fracture, they're going to have a limited upward gaze, which means when you have them look up, one eye is not going to be able to look up. So if you're seeing signs of entrapment on exam, that's a reason to get a CT, a CAT scan of the orbits and face to rule out a fracture. Everything else, it's going to be pain control and involving ophthalmology, facial surgery to discuss whether that repair is going to require surgery or not. Orbital fractures are best diagnosed, we already talked about, but CT is certainly the imaging of choice. And because these are kids, we do want to be careful with the radiation load. So again, if you're suspecting entrapment of the eye, that's an indication to get a CT. If you think it's just a contusion or maybe even a hairline fracture and they're not entrapped, you can discuss potentially not imaging them. And if they have a history of diabetes or they have a history of sinusitis or they're immune suppressed, you'd want to consider starting some antibiotics. All right, here's an important diagnosis. And just like corneal abrasions, you'll see this more often than you do anything else, which is traumatic iritis or uveitis. Now, the key for this, Officer Orman, is these patients present in a delayed fashion. So 24 to 72 hours after some type of eye injury, you think they're initially fine. They're going to come back with much worsening, dull, aching pain, some redness, and a lot of photophobia. On exam, you may see white blood cells in that anterior chamber, and you're going to want to consult ophthalmology for a dilated exam here and some steroids. And so If these patients come back, when?
They
Stoner Matt?
come back in a couple days now. It's like this chicken. I know why my accent changed. This chicken's just fine on day 1, but on days 24 to 72 hours, it's rotten.
Yeah.
Rotten, I tell you.
Exactly.
Totally like sand in your eyeball, man. I had that happen to me before.
Mm-hmm. No
Sand in
good.
my eyeball.
You know what?
It hurts, man.
You're a good egg, surfer.
Totally.
I like your style.
All right. This paper also covers some posterior segment injuries, but given the attention span of both of you, we're just going to skip right over this. It's not that important. You can read about it later if you would
Call
like.
optho, dude. Just call optho.
Just call optho, exactly. So in summary, Seidel-Stein teardrop-shaped pupils is concerning for an open globe. You want to put a eye shield over that eye, keep the head of the bed up, and call optho immediately. If you have an ocular burn, you're going to want to irrigate that as soon as possible, and you're going to keep irrigating until the pH is neutral at about 7. If you have a traumatic hyphemia, those patients get admitted if it's over 50% or they have a coagulopathy. Everyone else gets to be discharged home with less than 50%. And lastly, traumatic iritis presents in that delayed fashion that we talked about, typically 24 to 72 hours after the injury. Hey, boys, this has been fun. That's everything non-penetrating eye injuries we've talked about.
That was tubular, man. Totally awesome job, Dr. Morrison. Awesome job, tubular.